Greetings and welcome to Week 6 class. Before jumping into this week's content, let's take a moment to review what we've covered in Week 5. We explored the various numbering and filing systems, as well as record storage and general circulation processes. In Week 6, we review indexes, registers, and the overall health data collection process. An index in the healthcare setting can refer to a variety of things: master patient indexes, disease indexes, procedure indexes, and physician indexes. An MPI links a patient's record number with several types of common data elements, like demographics. The MPI can then be thought of as a legend or a map on how to locate a patient's record. An automated MPI is computerized and owns similar tasks, but with the use of an ADT or admit transfer discharge solution. A manual MPI requires manual processing of patient ID information on index cards. These index cards are housed in a vertical file. Think back to Week 5 and what a vertical file looks like. Regardless of the approach, organizations must avoid the duplication of patient records. There should be a singular control mechanism of the MPI so that ownership resides within a single department. There are several different efforts that this owner department can engage in to ensure that records are maintained appropriately without duplicates. A disease index houses diagnosis codes and the patients tied to them. A procedure index houses procedure codes and the patients tied to those. A physician index will list out the physician by an org assigned number and the patients that have been treated by them in an inpatient or outpatient perspective. This slide shows a sample of what a data entry screen looks like for a master patient index. Take note of the types of data being collected here in an electronic format. This slide shows a sample MPI data card that would be housed in a vertical file. Pause for a moment and compare and contrast these two MPI methods. This is an example of a disease index. As you can see here, the diagnosis is listed with patients aligned with these diagnoses directly below it. Similar to the example of a disease index, the procedure index will list out the specific procedures and the patients that have undergone them directly below it. This is a visual representation of a physician index, and you can see that it will also list out the patients seen during a specific time. Before diving into the content on this slide, let's define what a register or registry is. A register and registry will contain specific information about an event or illness. They are maintained by individual organizations, local and federal institutions, as well as private organizations. A case report form is the document submitted by a care facility or provider that provides a report to interested agencies, facilities, or organizations. For example, if I had tumor data, I'd use a case report form to submit this information to the National Tumor Registry. It is important to note here that there are several instances where organizations or providers are required to submit patient data to a specific registry. Now that we have an understanding of what these are, let's talk about the characteristics that make them up for a moment. These are often focused on specific diseases or exposure events like vision impairment, mental health, cancer, or the exposure to toxins. Data is also collected from several sources. It could be the provider, hospital summary, documentation, etc. There are always active investigations of specific cases as a direct source for referrals into this registry. Leads me to my next point. There's always follow-up investigations that are facilitated by this registry data so that new data is added on the persons enrolled. Last and most importantly, there is a certain cost element here. This is expensive work. Important but expensive because the collection across many data sources will obviously require more resources. Vital statistics are those data points collected for specific events in a person's life: birth, death, marriage, divorce, etc. The National Center for Health Statistics is the federal agency responsible for maintaining these vital records. Not to give anything away here, but I'd encourage students to remember this one moving forward. As we've stated, registries and registers are operated by a diverse grouping of entities. These include federal and state government agencies, individual groups of hospitals, non-for-profit organizations, private groups, and lastly, universities. A nice list of some of these registries and registers can be found in your course text on pages 262 through 264. Case abstracting can be either automated or manual as a process. This is an activity performed by the HIM department, specifically in Abstractor, so that patient information can be collected to determine payment status, generate specific indexes, and report patient healthcare quality data back to state and federal agencies. Case mix analysis is a study of specific patient types that are treated by a facility. These statistics can actually be used in a population health strategy and are increasingly important in today's health landscape. Automated case abstracting systems are typically a suite of software that allows an organization to leverage IT to make the abstraction process more streamlined. Some of the standard tasks are done automatically and require QA work once a report is generated. Manual case abstracting systems require individuals to manually enter patient data on a specific form. This form must adhere to strict data collection processes as identified by the institution. Manual extraction is not the norm in today's landscape, but some smaller venues rely on it to avoid the costs associated with an EHR. Home health is a perfect example here. A data set is a collection of related sets of information that is composed of separate elements but can be manipulated as a unit by a computer. In manual extraction, there must be a general understanding of what data will be required in the dataset so that a submission can be made into it. A data dictionary is a listing of all data elements and their associated definitions. This will be used as an aid to explain the exact data points and their specific purpose within a dataset. This slide lists datasets used for collecting and reporting purposes for healthcare institutions. It's important to note that the dataset will be determined based off of a specific patient type. These two datasets are also associated with the care of a patient. The Medical Information Bureau is used as a repository of information about people who apply for insurance. I'd imagine that all of us touch this one in some way, shape, or form. The National Practitioner Data Bank contains information relative to physicians and any unprofessional behavior tied to them in their practices. When a provider applies for privileges at an institution, this data bank is referenced prior to granting them this right. It's a safety barrier to ensure that organizations do not grant these privs to high-risk practitioners. Descriptive statistics in healthcare summarize a set of data using tables, charts, and graphs. It's easy to think of this as a visual representation of the story collected data is trying to tell. A sample of a bar, line, and pie graph can be found on page 272 of your course text. Data quality is incredibly important because we use this data to drive health policy, treatment, and oversight. Data has integrity if it's accurate, complete, and up to date no matter where the data is recorded. Data is reliable if it remains consistent. Data is valid if it conforms to expected ranges in a given area. Lastly, on this final slide, we take a look at the various types of statistics collected by organizations. There are many others out there, but these are the top ones that immediately come to mind. Admission data contains information regarding census counts in a variety of settings. Length of stay data includes data relative to how long our patients are staying during their encounters. We can look at total length of stay or the average length of stay for our patient populations. Discharge data is collected to measure health outcomes, facility utilization, and access to care for a patient. This data is used in planning and it's also reported to agencies outside of the organization. Something not listed here that I want to also discuss is readmission rates. This is getting a lot of play because if readmission rates for an organization are very high, chances are that a patient hasn't likely been cared for appropriately to begin with. Data is incredibly powerful if we know how to harness it, and this is just another example of that. But for it to be powerful, it must also be of quality, integrity, reliability, and validity. This concludes our Week 6 lectures, so take a minute to debrief on this new information. We reviewed indexes, registries, and registers in detail while also providing several examples. The textbook has a very good list of the various registers and registries currently out there that I encourage students to review in more detail. We then briefly reviewed the abstraction process and investigated the different types of healthcare statistics out there. Next week, we'll explore the applications of an electronic health record system in more detail, as well as a review of the regulatory landscape in general.